My name is Andy Kent and I'm Dean of the Faculty of Health, Social Care and Education, joint faculty between St George's University of London and Kingston University. I'm disappointed not to be with you today. I have a prior personal commitment that's taken me away. The conference today will be chaired by Professor Mary Chambers, who is Director of the Centre. I want to welcome you on behalf of our two universities and hope that you have an enjoyable and rewarding day. I look forward to reading about the conference when I get back to the university. Before I finish though, I want to say some words of thanks to Mary, who joined us in 2012 and set up the Centre for Public Engagement in 2013 and has steered it through 8 glorious years of important work contributing to public and patient engagement in science and health and social care science in particular. Mary, I hope she doesn't mind me saying, has had an illustrious career in several domains. She is a qualified registered general nurse and registered mental health nurse. Back in the day, she studied behavioural psychotherapy under Isaac Marks at the Maudsley Hospital. She pursued an academic career initially at the University of Ulster, where she obtained her PhD and where she became Professor of Mental Health Nursing. Prior to joining us in the Faculty of Health, Social Care and Education, she worked as a chief nurse at the local mental health trust, a trust where I spent most of my clinical career. And she was also Professor of Mental Health Nursing in that capacity. She's been an enormous asset to the joint faculty since she came here in 2012, and I and all of us in the joint faculty are deeply indebted to her for the work that she's done. Mary, thank you very much for letting me make a small video announcement in my absence. I really appreciate the opportunity to welcome everyone here and to thank you in particular for the outstanding work you have done and are doing on our behalf. Over to you, and thanks again for organising an outstanding day.
Good morning, everyone, and welcome to our 8th annual conference for the Centre for Public Engagement. And as Professor Kent has just said, I'm the director of that centre. Before we start our business, I would just like to thank Professor Kent for what he's just said. It was really very nice and unexpected, so very well received, and thank you. We chose this topic because it seems to generate a certain amount of debate and discussion, so I hope that we can add to that today. And I would like to thank you all for attending. We have over 200 people that have registered, so we have quite a good audience. This is being live streamed. Also, there's 5 minutes for questions at the end of your presentations, and audience can put questions into the chat box, and I will endeavour to monitor that and put it into some theme format. I think I will stop there and hand you over to Lynn Laidlaw, who is going to talk about reflections on the invisible labour and practicalities of navigating payment for PPIE. So Lynn lives with a rare autoimmune rheumatic disease and multiple long-term conditions. So her experience of trying to get a diagnosis and effective treatment prompted her interest in patient and public involvement in research and co-production. So she's involved in a number of research projects across the UK, and this year was fortunate to receive funding to co-produce some qualitative research as part of a small team of 2 patient researchers and a clinical academic. So Lynn, over to you. We look forward to hearing your presentation. Thank you.
Thank you, Mary, and thanks for the invite to speak. And I found putting together my talk extremely challenging, but I'm not sure why. And I suspect that I will lose my place like Boris Johnson the other week, but I can promise that there won't be any references to Peppa Pig. So I'm going to share some reflections from my own experience, and whilst I hope they will resonate with people, I can only represent myself. And I'm going to use the terms public contributor and patient researcher throughout, as that's how I describe myself, but I realise that others may choose different terms. And if I sound critical at times, I hope it's clear that my criticism is of the structures and processes that constrain us, not of individuals. And I just want to take a second to say a heartfelt thank you to the brilliant researchers and PPI leads that I work with who are supportive. And I think, well, I know that they are frustrated by the system, as I am. So I started my involvement journey about 5 years ago, and at that time I think it's fair to say that I was just so pathetically grateful to be involved. And it didn't take me long to realise that payment and expenses were a big issue, and that there is much invisible labour, both practical and emotional, attached. And I sit here as one of the usual suspects, the white, middle-class, middle-aged, educated female that dominates involvement. And the Black Lives Matters movement and inequitable effect of the pandemic has made me realise my privilege in a way that I didn't before. And I also realise that I'm involved in a lot of things because I have the time and resources to be, time and resources that a lot of people don't have. But involvement costs me money. So over the years, I've had to buy laptops, pay for software licenses, paper for printing, the endless cups of tea that we bought while we were travelling to meetings pre-pandemic. And no one wants to reimburse these costs, and it's not even reimbursing them. I think often that there's not a recognition that they are costs. And it's only recently that organisations have started to pay £5 towards people's IT costs for meetings. But I still see too many PPI adverts saying people will have no expenses because the meeting is online. And in my world, Wi-Fi, laptops and whatever are not cost free. These are costs that people need to pay. So it makes me feel very uncomfortable chasing payment and expenses. But why should it? I don't understand why I feel so uncomfortable about that. Why do we feel uncomfortable asking for the payment and expenses that have been promised us? And often I've had to wait 6 months or more for expenses. I mean, at one point I was due about 600 quid, and it just wasn't forthcoming. And I think in part it's due to being aware of some of the attitudes around payment, where people have, quite frankly, been made to feel greedy or somehow lacking because they want and expect payment for their efforts. I mean, where does that come from? You know, why are we made to feel that way? And this happens far too often. You know, often if I see a PPI opportunity advertised and the volunteer word is used, and I know that's shorthand for we don't want to pay you. You know, we are designated volunteer status, and as in many things in patient public involvement, this is essentially about power. We don't have the power to decide whether we will receive payment. And often the only power we have is the power to walk away from exploitative opportunities. But we walk away realising that other people don't recognise that they're exploitative, and that there's people there to take our place. And there's much invisible labour in keeping up to date with the PPI literature. I mean, I love Twitter, but I've come to realise that although I've made, you know, so many wonderful contacts and whatever there, about 90% of the opportunities I'm involved in, the people that I've met have come through Twitter, and that in a way has become work in itself, because I need to keep on networking on Twitter. I need to keep my profile up. Make of that what you will. answering the endless emails. On a Sunday night, my husband's sick fed up of me, sitting, sighing, ploughing through all my emails from the week, checking that I haven't missed anything. Putting together CVs, can you just write 3 paragraphs about yourself and come to an interview to be grilled by 3 people so we can decide if you tick all our boxes for this opportunity that actually we're not going to pay you for. And the debate over payment has become really reductive. It's about being paid or being a volunteer. And I think whilst there's an awareness that not everyone can accept payment for various reasons, systems are inflexible, and there's a concerning move towards putting people on the payroll or asking to see passports, etc. as proof of identity. And I think that that's really uncomfortable for a lot of people. And we need to get more creative. How can we treat people as individuals? If people's individual circumstances mean they can't accept payment, can training, IQ equipment, pay-as-you-go mobile vouchers, etc. be offered instead? And the Co-Production Collective are co-producing their payment policy at the moment, which I think is a great model to follow. And I have reflected that in my work in patient public involvement, I have had to look to my own development and seek out opportunities. No one has offered to help me do that, and which is just more invisible labour. And I want to mention here the importance of allyship. So it makes me really uncomfortable when I'm in a meeting with public contributors who say that they feel uncomfortable without or don't want to get paid. And payment's always a choice. No one is forced to accept payment, but there needs to be an understanding that one of the barriers to inclusive involvement is the lack of payment. And I want to mention Sarah Noel's great paper here, which was published this year, More Than a Method, which talks about the importance of trusting relationships, productive tensions, and two-way learnings as mechanisms of authentic co-production. And one of the central themes in their paper was highlighting how public contributors were reimbursed was a demonstration of how their input was valued, and that how that was so very important to come up with methods that suited everyone, to show, not just for people to say that they were being valued, but a concrete example of how they were valued. So in the past 18 months, myself, another patient researcher, Joyce, and an academic rheumatologist, Charlotte, had a research idea, submitted a grant application, and have been funded to do a small piece of co-produced qualitative research with a limited budget. Our budget is only £50,000. Charlotte is the principal investigator, as Joyce and myself realised that we didn't have the knowledge and experience to lead our research. And it's been a really steep learning curve for me. And some of the issues we have come up against is the work that goes in pre-funding that there are no resources to pay for. And again, I recognise my privilege as I had the time and resources to commit to this that others don't have. And Charlotte has helped me negotiate a contract that suits me and my personal circumstances. So I had to retire from my career on medical grounds, and after a long fight, managed to get an ill health retirement pension. The process of being dismissed from my career on capability grounds due to ill health was traumatic. I lost my career. I wasn't defined by the work that I did, but it was important to me. I lost my ability to contribute to the household finances, which was important to me. I felt judged and worthless. I never want to be in that position again. I'm only allowed to earn a limited amount of money each year on top of my modest pension. But I live with a rare complex disease which remits and relapse. For me, the ability to have some control over when I work, how I work, and patient public involvement is key. Inhabiting a body with lots of autoimmune diseases, which is out of my control, makes me value control over other things in my life. And I don't want to ever go back to the situation I was in when I became unwell at first. Becoming a formal employee again fills me with dread. But I recognise that a lot of people won't feel this way. So when we submitted the grant application, we put in full costs for me in the knowledge that I wouldn't be able to take them. But it was really important that we highlighted, that that we were going to be doing the research and what those costs were. So if we've managed to repurpose some of the money to increase the amount of time our patient advisory group will spend in the project, which is fantastic. And I have a flexible casual contract, which means I control the hours I claim for. And despite starting our research on the 1st of June, the last part of my contract wasn't sorted till last month, and I couldn't get paid till then. And again, I have privilege in that I was, you know, that was the situation that was okay for me. But this was an example of systems and processes getting in the way. And the invisible labour that Charlotte and Denise, the centre manager, put in, because they put in a lot of work and effort getting this sorted for me, and I just want to pay tribute, you know, to that help and support, which just means so much. And I think one of the quirks is that funders don't pay for equipment. So again, I found myself in a situation where I have had to buy a laptop and monitor to enable me to do this work. And I think, you know, so what I would say to funders is if you feel that co-production is important, then you need to look at the way that you fund and realise that supporting public contributors to co-produce will probably require a different approach to supporting academics. So I just want to finish by saying I remarked to Stan that this topic is like an onion. There are so many layers, isn't there? And I'm aware that my personal circumstances and the emotions I feel are very individual. I don't know if I'm being naive and idealistic, but it seems to me that the most important things and the issues around payment for patient and public involvement and co-production is choice and an understanding that we are all unique individuals with unique thoughts, feelings, emotions and circumstances. We need flexible policies that recognise that, especially from funders and academic institutions, but we also need allyship and support for the fundamental principle that people deserve some sort of remuneration for their labour, and the recognition that we all need to understand our individual privilege in this regard when we have it. Thank you.
Lynn, could I ask you about, did you say a co-production movement?
Co-production collective, which are at UCL and are funded by Wellcome, although I think their funding runs out next year, and they have co-produced all parts of they've co-produced their website, they co-produced their values and principles, and they're also at the moment co-producing their payment policy. Because I think often what happens is the institutions or funders decide what the payment policy will be, and public contributors, people that work in involvement, researchers, kind of have to stick with that. There is very little flexibility. I think that there are lots of really good people doing what they can in order to support individuals in a way that matters to them.
So I'll use chair's privilege here. So Lynn, is there how does what you produce interface with the work of Sylvia Bartoli, for example, NIHR? I
came to the session that you had before, which was run by the NIHR, and I think people are in difficult positions. I think that, like I say, people need to stick to the processes and whatever, but it just seems to me that a lot of this is about payment or not payment, whereas I think we just need to be more flexible and understand that if people can't accept payment for whatever reason, and it's not always just due to benefits, I think there are other people in circumstances like me, then what can we give people instead? Can we, if people need a laptop, can we give people a laptop as payment? Can we give them pay-as-you-go vouchers for their mobile phone? If people need supported in involvement, if they maybe want to move into more strategic roles and whatever, then training opportunities, paying for training opportunities, coaching for personal development. And I think we need to look at all of that rather than will we pay people or won't we pay people, will we give them vouchers or not. I just think it's more complex than that. Okay, thank you. I think probably we are in a position of privilege too, in a sense, in that
we get a small allowance for upfront funding for people to participate in the development of projects. But you're right, that is a huge financial drain on people, and it's so important as well because it's a condition of grant awarding bodies. So we really need to address that.
In terms of pre-work, Joyce and myself had this research idea, and we put a lot of time and effort, and a lot of that was kind of developing it, going over it in our mind, going out to speak to people in our networks and whatever. And there was no, you know, I'm caught between understanding that was our choice in a way because it was really important to us, but also that if we want to move towards co-production, as everyone says they want to, that often, you know, all that work pre-award and the wasted labour of, you know, we were lucky that we got funded, but if we hadn't got funded, then that would have been a lot of work and effort that would have just gone nowhere. And I think again, these are real tensions and issues.
So Diana, I have long been concerned about the question of liability, since I have no professional institutional cover. So if taking more of a leading role, is there an agreed position?
We have contracts for this research which gives us that, and we couldn't get rightly get access to, because we were going to be working with people's data, because it's qualitative research, and part of that was to have a contract with the university, which meant that we were covered with indemnity, which I agree is very important.
Moira, there needs to be equivalence in co-production, more than just fees. Agree with the speaker on opportunities, for example, mentoring, coaching and training. Next speaker is Foleki Siegel, and Foleki is going to talk about people and communities in the new NHS landscape, which is really very important, and we have a little project around that. So particularly interested in this area, and you work for Healthwatch, Foleki, as an independent champion for health and social care. You're the director of the South East London Healthwatch and works at the South East London system level to ensure that patient and public voices feed into government structures. So you clearly have a very extensive role. You work with Bromley, Bexley, Greenwich, Lambeth, Lewisham and Southwark, all at high level visibility, which is really important. And your work reflects your passion for ensuring that people's voices and experience are integral to service planning, commissioning and delivery. So look forward to hearing your presentation, Foleki.
Thank you very much, Mary. Good morning, everyone, and thank you very much for inviting me to join the conference panel and to contribute to it this morning. As Mary said, thank you for that introduction. My name is Foleki and I work for Healthwatch in South East London. And for people who don't really know, Healthwatch works with people and communities to listen to their experiences of care and to connect and support people to have a voice and influence how that health and care is provided for them. At Healthwatch, we believe very, very strongly that there is no such thing as hard to reach communities, but there are communities that are seldom engaged, there are communities that are seldom listened to, and there are services that are hard to access. So we also work with commissioners and providers to amplify voices, to address inequity and to improve care. And as Mary said, I work across South East London with lots of wonderful colleagues, and we try and bring the voices of just under 2 million people to the table, which is quite a daunting challenge. As many of you know, there's new legislation currently going through Parliament that's going to put integrated care services, or ICSs, on a statutory footing. And it's going to shift the way health and care services are planned and delivered. And I know when people think about this, how the system works with people and communities is not going to be at the forefront of their minds. But I do want to talk about it briefly and with some intention, and I hope I can communicate some of the significance of these changes and the opportunities that I believe there are for involvement. So the ICS Implementation Guidance was published last September of this year. And in it, there were 10 principles for the NHS to use as a starting point to firstly develop a system-wide strategy for engaging people in the community by April of next year. And secondly, the principles are supposed to be used to create arrangements for ensuring that representation of people exists in priority setting and decision-making forums. And thirdly, the principles are supposed to be used to gather the intelligence about the experiences and aspirations of people who use care and support. So really, the principles need to understand the community's needs. I'm just rattling through what they are now, really. It's about putting people's voices in the center of decision making. It's about the starting engagement really early and developing feedback, closing that loop that is often unclosed. It's about understanding the needs and experiences and aspirations that individuals have for their health and care, and using it all and using those principles to also find out if the work and engagement has actually made a difference to people. It's about building relationships with excluded groups, especially those who have been affected by inequalities. It's about working with organizations like Health Watch, yay, and voluntary and community sector as well. It's about actually giving and providing really clear information about the vision and the plans, being transparent in how the system works for people, using really good community development approaches to actually empower people. So stopping some of that parachute engagement of coming in and out and only talking to people when the system needs to hear something or wants to make a change. It's about using insight and engagement to really be accountable. And it's about learning from what has happened and gone ahead. So really, the guidance sets out an ambition, a really big ambition. I'd love to say it's new because the NHS has often said this, people are at the heart and there's a responsibility for providers and commissioners to actually do this. But there's a new ambition to put people on every level of what the NHS does and to reduce inequalities in access, in treatment and in outcomes. But the permissive nature of the bill will allow each system to do it differently, and there won't be a blueprint of how this can be done. So there should be and can be new ways of working, new models of delivery, possibly new services, new ways of rewarding people for their involvement. So that we have now a real opportunity to do patient and public involvement differently from the way that we have, and to support people to be involved in a way that really suits them. People must be present at every level of the new system to be listened to and their insights acted upon. This means, of course, within research, which we're talking about today, but within provider organizations, at primary care networks, at borough level, within provider collaboratives, and at the system level. And this should be resourced adequately. It is only fair that this is done this way. It allows a wider pool of involvement than those who can afford to be involved in programs, and it helps shift the power dynamic in the room. Listening to people and learning from their experiences offers a change really for the better. The pandemic made more visible massive inequality and appalling outcomes for some communities. But the response to the pandemic and to the COVID-19 vaccination showed that working directly with people and their communities and in real partnership will make a difference. People's voices were sought out, they were welcomed, they were listened to. And we also learned in this about the lack of trust that people have in the system. So we need to, now that addressing inequalities is front and center of thinking, this can only go hand in hand with good quality conversations and involvement with the people and communities that live and experience the inequity and who have generally not been involved. I know that people with lived experience are better regularly involved in designing and shaping research, as Lynn spoke about her experiences, and in mental health services. But in acute services and along pathways, involvement is lagging far behind. And sometimes this is because there is an array of competing agendas being delivered under incredible pressure, often with targets and deadlines attached. And sometimes it's just because the qualitative insights and approaches aren't valued. So there needs to be changes in planning, there needs to be resources in the leadership, and change will require bravery. We can evolve that spectrum of involvement. We can create new opportunities and new payment models. So what might be able to help? Obviously, there's no one way of creating change. It's got to be about lots of different methods and working together to look at different tools. But it's also going to be about really having a shift in the culture of the way that we work. In Southeast London, the Health Watch and the ICS together have co-produced a new approach. So we have a dedicated senior role hosted by a Health Watch that brings a consistent and coordinated voice and insights from the diverse people and communities that Health Watch works with to engage in the ICS decision-making bodies and its work programs. At the heart of this is shared decision-making. So people's experiences have directly informed decision-making, priorities, contacts, quality improvements. It's a full-time role and it is resourced appropriately as such. And as ICSs move to a statutory footing next year, we're likely to see more patient director roles developed in the NHS. And in these roles, we have patient leaders and ordinary people with lived experience of care who are employed in senior positions. They'll have portfolios to deliver against, but they'll be given equal status around the board table to make change and to influence how people work. Now, this is going to be great, and it could be another way to hardwire systems into a business as usual approach to involvement. But only, of course, if patient directors are supported by a cohort and huge pools of other patients, service users and carers who are trained, resourced appropriately, and supported as partners in service improvement. Everyone who gets involved in the NHS should feel listened to and should feel that their voice is valued. But everyone in the NHS should feel confident about listening to people as well and hearing what matters and acting on it. And it shouldn't just be the responsibility of engagement practitioners, PPI teams, and researchers who've traditionally involved people in their work. And I'm really hopeful that the new bill will be a good step forward in the development of patient involvement and people participation through to real, genuine co-production. Thank you very much.
Thank you, Falaki. That's great, and a real introduction to what's happening with Health Watch and the new organisations. So.
And Jackson has pointed out that there's a huge distance between PPI, who supports a couple of research trials, to a patient director role, and have commented that, you know, they're pleased that we're looking at this. And absolutely, I think that it's about the models and it's about finding which levels. One of the things I really believe in, and Health Watch is very clear about, is that there needs to be real involvement at people at different levels. And there has often been people in the feedback loop and in the initial level of information and asking. But where the patient director role comes in is this is a board level role where someone has a coordinating influence and can actually sit with equity at meetings to bring that lived experience more consistently and regularly to the system. And so that's part of what it is. There's also a question here about, are the resources you have worked on at HealthWatch available through our website? Yes, as I mentioned, there's a HealthWatch in every borough, and each of them have their websites. So there isn't one HealthWatch, but there is a local HealthWatch across each borough. And I'm sure when the notes and the links to this go out, I'm happy to send the links for all the HealthWatch websites and the work that we're doing. And in the annual reports for the HealthWatch last year, there's a summary of how this role has helped influence changes in the equality delivery system, in the equalities priorities for the CCG, in the engagement assurance and the processes around that, and how people are involved in that, in the recruitment of people into the engagement assurance committee within the ICS. So there are lots of examples of where this role has made a difference, and having someone who's paid consistently to work with the system is making a difference.
Okay, thank you for that, Falaki. I see a question from Moira. Please, can you share one or two service changes, improvements that you are proud of arising from community involvement?
Well, one of them, so maternity, I'll go to maternity during COVID. The system wasn't ready for COVID and the world. Nobody was. The pandemic hit everyone by surprise. So lots of things shut down. And one of the things that shut down then was access for partners to support women during their maternity care. So at the door of hospitals for appointments, women were having to go in alone for scans and even to give birth. So some of what we did was bringing people to the table with commissioners and with providers to talk about how this could be amended so that the significant stress and challenges that women were facing could be alleviated. And I'm pleased to say that this did change. This did change. There was a agreement across Southeast London that partners were going to be allowed into the hospital. All they had to do was exactly what the women who were pregnant had to do: wear masks, sanitize their hands, but that they could have support during their maternity journeys. So that's one example. And another one would be some of the work that we're doing now around waiting times and the anxiety that it causes people, not knowing the fact that you're put on a waiting list and you have no way of understanding really what that's going to mean about when you're going to be seen by clinicians or the timeline. And so we're helping with patients at the table, talking about virtual waiting rooms and virtual ways of actually getting more information regularly to support care while you're waiting, but also to alleviate some of that stress and anxiety that people feel during that time. And these are all things that were brought to the table by people to the system, and changes are being made because of that.
Okay, thank you, Falaki. What if communities want to co-produce a different and more democratic health and care system? So we want to know how much scope is there actually for communities to change what is already planned? Patient director role sounds like incorporating people into the existing system. So who would you like to address that?
There is permissiveness in the new bill. So systems are supposed to be able to work with their communities to really look at how health and care is delivered for us. It is, so there are changes in place and there's a framework, but certainly in Southeast London, there's a big push to look at subsidiarity, to look at how more and more people can be involved and co-produce how services are delivered and how people engage with the system. I know that some of it will seem as if it is existing systems, but that's the challenge that we have, to try and encourage that culture change that I talked about, so that it isn't business as usual, and that so that things do look different and become different.
Thank you. Lynn, did you want to say something about co-production before we move on to Savi?
Yeah, so I just want to say a couple of things. That one, we need to look at our definition of what a community is, because I think a lot of people think about community as a place, whereas for someone like me that has a rare disease and other things, community is people that I engage with, and it's not, I'm not actually involved in anything locally. I'm involved in a lot more UK wide than I am in Scotland, because patient and public involvement isn't funded in the way that it is in England. And all I would say in co-production is that there is a lot of faux production out there. I am often told that I am part of a co-produced process, but I'm not, and it's really, it can be very challenging and uncomfortable to be the person that's continually putting your head above the parapet to call this out, and it is emotionally draining. And yeah, and you know, I think co-production is a buzzword, and you know, we talk a lot about methods, but it's not, it's a way of working. It's value and principle driven, and that's what people really need to understand about it, not here's a framework to follow it, oh look, we've co-produced, because you ain't.
Thank you very much. Well, there are a number of questions, so at the coffee break I will read through them and see if I can get some themes that emerge from it. I would now like to introduce Savi Hensman, and Savi's going to talk about valuing involvement, what kind of work. And Savi is the Patient Service User Care and Public Involvement Coordinator for the Applied Research Collaboration, the ARC South London, and a member of Service User Research Enterprise at King's College London. She has long worked in health and social care involvement, being active in various communities, especially on equalities and human rights. And Savi is also a writer. So over to you, Savi.
Thank you. In talking about valuing involvement, what kind of work, I'll share some thoughts on the challenges which can arise even when research organisations offer payment for time and expenses, addressing some of the issues that Lynn raised, in the context of social inequalities and what activities society values. These will be my own views, not those of any organisation, though of course informed by the years that I have worked in involvement and in other capacities. As well as being an involvement coordinator, I am or have been a carer or support giver for people in most of the areas of health and social care covered by the research collaboration for which I work. And over the years, I've picked up the odd long-term condition myself, though not any of the ones covered by my ARC. As well as being an employee, I am occasionally self-employed. I am and have been an unpaid volunteer for organisations of a very different kind from a university, and have been involved in public services in different capacities. So the question of work and what kind of work involvement is one of particular interest to me, and I might approach this from different angles. Lynn earlier outlined some of the problems which patient, service user, carer and public contributors in research may face, which are partly to do with institutional bureaucracies and rigid systems, which are often not designed for purpose. Our ARCS policy is to offer payment, and we're trying to streamline processes to make this faster and more convenient, with some success. We are trying to make sure that there are public and community contributors at various levels of the structures and so forth. But there are deeper issues which further guidance and more responsive finance departments, important as these are, or even more funding before projects are off the ground, which is also important, are not enough on their own to solve. These include the requirements, if people are involved on certain and who are on certain kinds of benefits, for them to supply copious information about their activities and income. And issues around tax can complicate matters further. These are society-wide issues, ones that the research institutions on their own cannot fix, though they can maybe influence them. This can put people off from getting involved, since it can feel and be intrusive, and it can be tricky to handle. For instance, some of the systems are quite inaccessible for some disabled people, or people who are digitally excluded or not fluent in written English, and it can feel risky with the possibility of interruption in one's benefits and potentially harsh penalties if one is seen to slip up. And for people on very low incomes, that can be a significant risk, which can put them off from getting involved. This is linked to an emphasis by successive governments on work with immediate economic value being seen as perhaps especially important, preferably where someone can make a profit. And people may be pushed towards paid work, even if poor pay and conditions might affect their health and well-being, and this might not be ideal for them or the best way in which they could use their time and talents for the benefit of wider communities. So there can be risks of being seen to, quote, work, unquote, in the usual sense, which may lead to the presumption that somebody is then wholly available for the labour market, that they can work full time in almost anything at any hour of the day and night, with enormous flexibility and so forth. There's an opposite problem for asylum seekers, in that they have to be careful about the kind of work that they may do, because this may be seen as putting perhaps too much claim on belonging here, when people have not yet been certified as truly belonging. And with a recent extension of the hostile environment, there may be a wider range of people affected, which again may deter people from getting involved in various capacities. But emphasising the difference of some forms of involvement, for instance, being on an advisory panel, from, quote, regular work, unquote, may seem like downplaying the value of that involvement. And of course, it is crucially important in many ways for good research and for institutions that actually reflect the needs and experiences of the people who may be most affected by health and social care inequalities, and whom the research is whose experience the research is ultimately expected to benefit. However, there are ways in which certain roles are rather different from being that of a standard employee low down the food chain in an institution, who can be hauled over the coals by bosses if they're not towing the line. I think the independence of advisors is important. So there are some similarities, for instance, with consultants who may be brought in from outside. I remember from the days of supporting local involvement networks and patient and public involvement forums, which came before Healthwatch, that members of these might be able to say things which NHS staff knew, but they couldn't voice directly, or which went unheard when they said it. And I think that's perhaps one of the important rules of Healthwatch that shouldn't be underestimated, of perhaps speaking truth to power. And that those involved also in a research setting may be the ones who flag up issues that might not otherwise be regarded. Though again, there can be a lot of questions around power and status that may arise, so those insights may not be fully heard, or institutions or research culture more generally may push research in certain directions, so that even if everyone round the table recognises that what's being said is important and valuable and might actually improve things, it may be quite difficult to put it into practice. Given the evident importance of research on health, social care and their determinants by any criteria, which we've seen over the past couple of years, perhaps if the government wants to encourage more people and a wider range of people to be involved or even participants in research, a disregard by the Department for Work and Pensions, Her Majesty's Revenue and Customs and other government agencies of modest quantities of time and money for involvement or indeed engagement or participation in research might be helpful, as well as saving a lot of staff time as well. And I think I'm not the only person to be airing that as a possibility, but it would, I think, perhaps save the state more than it costs, not to be spending a lot of time and energy tracking down fairly small payments to people, which actually result in real benefits for research. If we really want to be a society that values research. There are also underlying questions which arise about what kinds of work society values and how both to strive for equality. For instance, somebody shouldn't be underpaid for being disabled or a woman or minority ethnic, while also asking questions about society's valuing of certain kinds of work seen as being of economic value or at least measurable in similar ways, and of people earning more as somehow more valid than everyone else, as if those in the commanding heights of political and economic power are worth many times as much as hospital porters, farm workers, or people whose lived experience is enhancing research. We may not agree with this, and I think many in the research world wouldn't, but it can be difficult not to be influenced, I think, by society's judgments of what matters and who matters most. Meanwhile, forming and maintaining caring relationships, serving communities and creating things of beauty or searching for truth may be treated as if they don't really count or don't count as much. Yet I'm aware that self-care can involve considerable effort, and from experience that being a carer, a volunteer, including a board member of voluntary organisations, which I would say has been especially demanding for a lot of us during the pandemic, or an active member of groups in which no one is paid, can be as physically, emotionally or intellectually demanding as paid work, and indeed as highly paid work, I would say. And then there is perhaps an alternative approach to the value of work in the academic sphere, though this is under pressure today amidst commercialisation. And also there's long been a risk of, or trends or aspects of elitism, and perhaps an emphasis on supposed objectivity as making the work more valuable, which can devalue knowledge derived from people with lived experience, especially if they're facing economic hardship, discrimination of one kind or another, or both of these. In addition, there are some people, for instance, certain ministers of religion, who receive a stipend. This is money not meant to reflect the value of work they do, and where their specific activities aren't tightly controlled, but rather free them from a struggle to make ends meet, so that they can draw on their capabilities and commitment to do something they and the community think is important. If and when we have a society which is more supportive and less competitive, in which diversity is more honoured, different forms of knowledge truly appreciated, and participatory democracy promoted in a nurturing rather than hostile environment, I believe questions around valuing involvement may come up with different answers, or at least take a different shape. And while we're dealing with the everyday realities in the here and now, which are vitally important, and I take on board the importance for institutions of listening to the voices of those who are involved and trying to make the systems as friendly and supportive and inclusive as possible, I think we shouldn't assume that this is how things always have to be. I'll hand over and open this up for questions and comments.
Thank you very much, Sally. That has given us food for thought and ties in quite nicely with previous presentations. There's a lot of questions about payment, as you would expect, the challenges and the issues of form filling. Stephen has raised a number of issues and comments on that. Also, there's Stephen asked a question about why in this electronic age do we have to have handwritten signatures? Perhaps that varies from organisation to organisation. Peter asked when is proper ring fence money for PPI and a standard rates going to be available? And that was the same person who made the comment about the handwritten statements.
I think that in terms of payment systems, not all organisations do expect handwritten signatures, and there can be a variety of ways of paying people, especially if they're being paid regularly, that can make it easier, but it does vary from one system to another. So it may be worthwhile for those who are public contributors to work, and those who are involvement coordinators or similar, or lead researchers, to look at ways of making their system work as easily as possible, though there may be some difficulties that are insurmountable. With regard to payment, I think part of the problem is that a lot of the time peer involvement doesn't get costed in properly into research proposals, and I think that the more people are encouraged to think about that from the outset and given guidance on how much to include, the better it will be. But I recognise also there can be a pressure to have a kind of pipeline of research. So this may push forward what's seen as economically valuable, and if involvement isn't built in at the beginning, it can be then dropped out of the costings, or these can be squeezed quite heavily. But yes, I think there is a lot that can be done at the moment for an encouragement of costs to be built in, because otherwise it can be very difficult to include those at a later stage, though there can be some flexibility, and I think when involvement is prioritised enough, that can make a difference.
Thank you, Sally. Zoe has highlighted that NIHR with the HRA and other national administrations is trying to address the source issue regarding payment, which is HMRC guidance on whether involvement is and at what level is taxable. So that is a challenge. And we did have a presentation from NIHR and Sylvia Bartoli earlier this year on the work that they were doing around payment.
Yes, I would recommend maybe having a look at that on the YouTube channel, but also for anybody who hasn't seen the payment advice on the NIHR website, the guidance. It is helpful, and for some of the organisations associated with NIHR, there is access to specific benefits advice. This is something that we wouldn't give ourselves because it's a very specialist area. But but for some organisations, it may be possible for individual public contributors to get that advice, which is a very helpful resource. Otherwise, if your institution isn't part of that, there may be a way of linking up with a local advice agency so that people can get the specialist advice they need. But there's also advice about the kinds of letters that might be helpful to people. I recognise this is a challenge for many. And to the question about our ARCs, applied research collaboration, sharing best practices, yes, there are links among ARCs and we do to talk to one another, but university systems or other institutional systems can be quite different from one another.
Thanks, Sabi. Helen asked a question: what if communities want to co-produce a different and more democratic health and care system to that being driven through by the government and the NHS leadership? How much scope is there actually for communities to change what is already planned? Patient director role sounds like incorporating people into the existing system. One for you, Falaki.
In a sense it is. I think it's probably unrealistic for us to hope, we would like it, for the system to change entirely overnight. I think that it just won't happen, no matter how hard we all push for it and shout out the door. So I think we have to deal with the incremental changes. And I think the role of a patient director is one of such changes. And even that is a challenge for many organizations to accept, that people should have that equal footing and should be resourced equally at a very senior level to cover all their costs, but also to recognize what they bring to the table. There is scope, is my understanding, for local changes, and I think that's why the law that's coming out is supposed to be so permissive. So there is supposed to be an opportunity for people to be involved in scoping how health and care is delivered locally. It's supposed to be much better and closer to the populations than it was. That's why there's supposed to be opportunities at neighborhood levels now for real engagement and involvement. So primary care networks are going to have a responsibility now as well to actually involve and engage people. And the primary care networks include not just GPs, but everybody who provides health and care locally in a neighborhood.
Patient directors in particular is something that we'd like to see within all NHS trusts, but not just patient directors really. What we think is that within, and I'll come on to this within my talk, but within the entire structure, there should be lived experience roles, right from that from your peer support workers, through to your band 5, 6, 7, 8, 9, right through to your exec level. There's huge obstacles to this, horrific discrimination, which probably come on to a bit later. Bigging up completely what Falaki is saying. So I think the role of patient directors seems to be going down rather than up, which is very sad, because the very few that we have within England, as people have left the roles seem to have disappeared, which is very, very worrying.
Thanks, Tamar. A quick question, I think, for you, Falaki, from Peter Atkins. Healthwatch England and National Voices should be working with a wider variety of universities nationally in supporting the good work that is being done in PPI involvement in education and research. Would you like to respond to that?
I can take that back to Healthwatch England. I work for local Healthwatch, but I can absolutely take that back as a comment to Healthwatch England.
Okay, well, on that note, I think it's coffee time. Thank you very much.